Hi, everyone. My name is Jared Katz, and I'm the founder of the Chiari project. Today, we are going to have our first Chiari and Excercise Roundtable. We will have Dr. John Oro, who's a Chiari neurosurgeon. We will have Dr. Krista August, who's a physiotherapist. We also have personal trainers, Gabrielle and Michaela. Dr. Oro is going to discuss the physiology of what's going on inside the brain, the Chiari brain, when exercise is occurring. Dr. Krista August is going to take us through posture and stabilization. And then Gabrielle and Michaela, who both have Chiari malformation, are going to give us some of their personal experiences and tips regarding personal training if you have Chiari malformation. So let's get started with Dr. Oro. Thank you very much for tuning in, by the way, to all of my fellow Chiarians all over the world. Thank you very much.
All right, so we're going to talk a little bit, obviously, about the Chiari One Malformation. I'm retired from clinical practice currently, but still advise a surgeon at the Colorado Chiari Institute, and I'm working on a surgical manual as well as a book on the Chiari malformation. Why don't we go to the first slide after the next slide?
There we go.
So I have three tasks. Describe some of the neuroanatomy of the Chiari One malformation. And by the way, I'm sitting up much better than I did right at the beginning. I need to also show how the tissues at the base of the skull move with cardiac pulsations, and then briefly review head and neck pain in the Chiari One malformation. Next slide. I'm sure I won't be able to, I don't think you see my pointer, is that correct? Okay.
Correct.
So basically, the two large C-shaped fluid spaces, of course, called the ventricles. There are choroid plexus, little tufts of blood vessels within those ventricles, and that's where we continuously secrete the spinal fluid as an ultrafiltrate from the blood itself. But it has a very specific path that it has to drain out of. From those large lateral ventricles, there are two small little tunnels to the third ventricle, kind of there within that center of the C, if you will. And then the third ventricle has this very narrow, long tunnel, if you will, to the base of the skull. So that's the aqueduct. At the base of the skull, the cistern there has three drainage pathways. And then the spinal fluid circulates in the spinal canal itself. So it's this ongoing, continuous circulation with each heartbeat. CSF is produced. It's reabsorbed. I don't have the slide for that. I wasn't going to get into all of that. But the bottom line is that it spreads to the surface of the brain, which provides the buoyancy. And it gets taken up by these, what are called choroid plexus, within the large veins, and heads back into the blood system. So it's, again, this ongoing circulation. Of course, we're talking about the base of the skull today. We can see the cerebellum hanging under the upper brain. And next slide. And there is a beautiful Netter slide that actually, I guess, more clearly describes this. The red vessels, or the tufts of vessels that create the spinal fluid with each heartbeat, the circulation on down to the brain stem, to the fourth ventricle. There's that little red tuft that you see within the fourth ventricle. At the bottom of that red tuft, you can see a little opening, the foramen of Magen D. And those little white arrows indicate that the fluid needs to get out through those. And then it circulates back up. Again, follow these white arrows. And then go back to the top of the brain. And in the center, we have the large sagittal sinus. There are little tufts within that sinus called arachnoid granulations. And that's actually where the spinal fluid then becomes part of the blood system again. So now, back to the base of the skull, that fluid pocket where the spinal fluid is coming out from within the brain to around the brain is the large cistern. So it was called the cisterna magna. It's very important to us. Of course, Chiari malformation develops in that area. So again, this is normal anatomy. Next slide. And here's a beautiful slide by the Barrow Neurologic Institute that you can see. It's a side view, obviously. You can see the cerebellum. You can see the foramen of Magendie, that fluid pocket, that cistern that is below the cerebellum, below the tonsils, and behind the brain stem. And they've well illustrated all the anatomy in this area. So that's a happy situation. Next slide. So looking behind, and this is again normal situation, the cerebellum has these two little tufts, if you will, or lobules, and those were called the cerebellar tonsils. Yes, occasionally, I remember one husband, his spouse was there with the Chiari malformation being evaluated, and he finally just had enough. He said, wait a minute, we're not here to discuss her tonsils. So obviously not the tonsils that we commonly know. Now, this is a high traffic area. It's in particular the vertebral arteries as they're coursing from C3, as you can see them there, up through C2 laterally, and then curving into the skull to become the basilar artery, which feeds primarily the brainstem, but obviously a huge importance to being vital, if you will. And then there are nerve roots that you can see there, yellow. They're almost a little spidery looking. Cervical 1 root is often absent in patients. Cervical 2 root, so the second nerve that you see at the back of the spinal cord, is important. That reflects back to the back of the head, upper neck, and pain can radiate following that C2 distribution from the back of our head forward to the forehead. So some of the questions we ask to help understand, is Chiari really the problem here? And that is what happens when you cough and sneeze. So you do a Valsalva maneuver. It's a bit complex, but the bottom line is that you have this sudden tension in your head because of obstruction from the Chiari malformation, and your head wants to blow off, if you will. So there, we'll talk about pain a little more. Next slide. So, it's this one study from years ago that defined Chiari as 5 millimeters. Now, it's a useful measure. On the left, that image there was the image that was initially published when this article was written many years ago. So from A to B is the hole at the bottom of the skull, and it's the large foramen. So it's called the foramen magnum. We see the brainstem turning into the spinal cord. We see the cerebellum. At the bottom of the cerebellum are the cerebellar tonsils that we just looked at. And this paper, and again, it holds up pretty well, defined borderline Chiari as between 3 and 5 millimeters of herniation. 5 millimeters or more is then called the Chiari malformation. Now, there are 2 other variants that we need to talk about. There's a rare Chiari 0, where the tonsils don't hang down 5 millimeters or more. They may just hang down 2 or 3, but the anatomy of that area is formed in such a way that it's crowded anyway. And some people can have significant Chiari symptoms with just a few millimeters of Chiari herniation or of tonsillar herniation. And therefore, that was called Chiari 0. There's also a worse malformation, and one group decided to call it Chiari 1.5. And I have no problem with that. It just allows us to see that in some people, it's quite severe what's happening in that area. And we're going to actually look at some MRIs. But again, this is the document, the paper that defined 5 millimeters as the key number. But when we see patients in the clinic, the key thing is, what are the symptoms? Are they consistent with the Chiari malformation? And what does the anatomy really look like? And so the number is not the be all, if you will, of the diagnosis. Next slide. This is a severe malformation, and I don't have my pointer, but the B there on the MRI, it's a sagittal side view MRI. The B is the brainstem. In that area of the brainstem is the medulla. Nausea, vomiting, cardiac functions, respiratory functions, all the tracts that are going up the spinal cord, so the sensory tracts, all the motor tracts that are coming down the spinal cord are right in there, and that's being just choked. I mean, there's no other way to put it, but it's being choked. And the T is the tonsils of the cerebellum, which are forced into a point in this area. They hang down just below cervical 1. Cervical 1's a little hard to see, the bone posteriorly there. And what's happening with this, and there's a lot of debate as to what the mechanism might be, but what's happening is fluid is driving into the spinal cord, and that's a syrinx, and that is with an S there. Fortunately, that's a relatively small syrinx. I've had folks come in that have a syrinx from cervical 1 or 2, pretty much all the way down the spinal cord. A syrinx can be a paralyzing condition. And if there are any golfers out there, in the early parts of the 19th century, 1900s, early 1900s, Bobby Jones, who numbered golf clubs, and was a famed golfer. He had 2 ticker tape parades in New York City when he won the British Open. He was just this giant of a man, if you will. In his 40s, he had given up professional golf, but he was starting to have weakness in his hands. He eventually went into a wheelchair, and basically he was diagnosed with syringomyelia, and no real treatment was given at that time. There's this beautiful photo of him. I should have put it on here. He's at St. Andrew's course in Scotland. He's in his wheelchair. You can see his hands are on the sidebars of the chair. You can see the atrophy in his hands. And a reporter asked him, he said, "How was it to be such a giant in sports and now live your life in a wheelchair?" He's very straightforward. He said, "Remember, we play the ball where it lies." So there's a lesson there. Next slide. Another MRI, the medulla, the M I've got there is the medulla, the lower brainstem. It's stretched, it's elongated. T is the tonsils. They're jammed to cervical 1, that little round bone you see at the posteriorly. There's the arch of C1. There's no argument that that's a bad Chiari 1 malformation. Next slide. Actually, you'd call that a Chiari 1.5. Here, there's so much crowding and herniation and distortion, if you will, that most of the medulla is in the upper cervical spinal cord. Next slide. And then I wanted to show a motion when we do surgery, before we take bone off as needed, before we open the dura, the tough sac around our brain and our spinal canal, before we open that, we do ultrasound so we can actually see what's happening in motion. So I'm going to now have this lady in the operating room with her face aiming downward. She'll be in a prone position. Next slide. All right, so this is the same case, just to kind of reorient yourself. So we're going to operate on the back of her in the occipital area, upper cervical area. So she's going to be in this position. Next slide. Now to the left is a scan of the MRI, a very detailed scan. You're seeing the tonsillar herniation. You're seeing the stretching of the medulla. There's a little heap of tissue dorsally at the back of the medulla from just this repetitive pulsation. Now, on the right is the actual ultrasound. So the dura has been open. There's a little fibrous tissue on the dura. Those little white specks within the fluid are just little bubbles there. We have not opened the dura yet. We're going to then gently lay an ultrasound probe on the sac itself to see what's happening. Next slide. And that is with each heartbeat. Each heartbeat, the pulsations, the brain's expanding, and the tonsils are herniating, and it's rocking the brainstem. It's causing that heap that you see there. And so imagine this person coughing and sneezing. The brain's going to shift downward, the tonsils are, and it's going to block the flow of CSF in the head. The dura has the pain fibers. The brain does not feel the pain itself. It's the dura has the pain fibers, and they're going to feel like their head is going to explode. The other thing to talk about at this moment is if you want to crowd her further, let's look at the left slide, the MRI before surgery. The way she can crowd herself in that area more is to look at the upper cabinets in her kitchen. Or look up. So one of the questions to help me understand, are they really suffering from Chiari malformation, is I ask them, how do you do when you look at the upper cabinets? And it's invariable that they'll usually say something, oh, I don't do that. I let my daughter do that. Or I have my husband do that. Or I step back and look up. Because if they look up, they're crowding even further. They're increasing their headache. Next slide. Next slide, I think then. Okay. Yeah, that's just more in detail. Again, it's this, it's amazing. You know, I can't have them cough while they're in the OR, obviously, but I can't imagine what's going on in this area. This is really a very challenging disorder. Everybody in this group understands that. I think what the Kyrie project is doing is wonderful. We need to reach out more and more. So many patients suffer. My nurse practitioner and I did a lot of research work with me. I asked her once to look at the average duration of a group of patients from symptom onset to diagnosis. And it was 6 years. On average, it's 6 years. And folks are discounted. They're often discounted in the emergency department, given sedatives or anti-anxiety medications. So this can, I mean, there's obviously more recognition with all the effort that's going on nationally and even globally, but still today, there are going to be people that are going to, you know, be sent home with anxiolytics from the ER, and nobody investigates further. So it's an honor, if you will, to be part of this mission. That might be the last slide, but next slide, if there are any. Oh, okay, yes, thought I was done. So briefly, pain physiology, I was asked to comment And, pain is simply a complex experience. There's not just the fibers that are sending us the pain fibers, but within the brain, the dorsal posterior insula. So if you think of the side of your head, just a little in front of the ear, there, the temporal lobe, there's a pathway between the temporal lobe and the frontal lobe. It aims in and back posteriorly. So when we separate that area, which we sometimes have to, and you're going on the surface of the brain, so you're not invading the tissue itself, but at the back of that opening is what's called the insula. And so that in studies is sort of quantitates the intensity of the pain. But there are other areas in the brain, the thalamus, in particular, this nucleus that I have here, the VPL, relays some of the pain signals. The parietal lobe, which is back behind the temporal area, helps us, it organizes our interpretation of the pain. Is this something I can deal with? What's the character of the pain, and those kind of things. And the amygdala, which is deep within the temporal lobe, a rounded area. It's the fight or flight area. Fear responses will trigger our amygdala. Well, pain also, the threat of pain also is registered in the amygdala to decide the intensity of that threat and whether there is anything that needs to be done. Somebody that has recurrent headache pain may assess that they're not going to need anything different to do. They've learned to accept it. A pain that comes out of the blue that is, if you will, somewhat new to you, that might then be received more as of a threat of why did that occur? Why did that pain develop? Next slide. And so as far as continuing with head and neck pain in Chiari malformation, so again, the dura has the pain receptors. In the posterior fossa, so that compartment where the cerebellum is called the posterior fossa, and the dura in the upper cervical spine are all innervated. And we saw how jammed that area can be. And coughing and sneezing can suddenly distend that dura, and that's why there's this intense pain. Where does it happen? Back of my head, it feels like an explosion, and it seems to radiate forward. Not everyone has exactly the same description, but that's a very common description. So again, this crowding can trigger, but the C2 nerve root, C1 again, often is small or even non-existent. C2 is important, again, innervating the back of our head, upper neck, and then up to about the hairline, if you will, in the forehead. So I think I've gone over those last couple points. Next slide. Okay. Well, I think that's it. I'm happy to take any questions that there might be. All right, well, thank you.
Thank you, Dr. Jared. I don't see any questions currently.
Mike, they could write their questions in, I think we're getting one question in here.
I have one. Nadia Jones. Yes, please. Oh, answer live. Maybe I'll hit the answer live. Can you hear that?
I can give her access. There you go. Nadia can talk now.
Hello, can everyone hear me?
Hi, Nadia.
Oh,
yes,
hi, Nadia.
That's much easier than trying to type it out. My question is, Dr. Oro, what might be some reasons that individuals who have been decompressed, the MRIs look much better as far as the flow is concerned, but they're still having some symptoms, especially with the pain?
Well, very good question. I mean, in broad sense of things, we have to keep in mind, is there anything else that's coexistent with the Chiari malformation, sort of to begin with, if you will? Having Chiari doesn't rule out the possibility of other pain sources. Are there degenerative changes in the upper cervical spine, as one example, if you will? But people that have ongoing pain, yes, we do see, and I've probably operated in just over 100 patients who have come for evaluation for what we call a failed Chiari surgery without adequate benefit. There's some obvious issues that we work to identify to see if there's a solution to the problem. And there are a handful of these. I've lectured in a number of national meetings on this, but number one, is the bony decompression adequate? What I see in follow-up patients that are referred to me, we will often do a 3D CT of the skull. So it's like a model of the skull. You can rotate it on the computer. And sometimes the bony decompression has been very shy. You could imagine maybe that surgeon hadn't had a lot of experience in the disorder.
That's what happened my first time.
Okay, restricted bone, they come in. You know, I remember when I first got involved with the Chiari malformation in the mid-90s, and I asked my professor at that time, I said, so how much bone do you take off? Oh, you just take off some bone. Well, how much patch? Well, you just create a patch. I mean, there was really not a lot of guidance at that time. So we've learned to assess the bony decompression. What about the patch, the dura patch? What about the arachnoid? The arachnoid is a thin membrane just on the inside. So when I review cases, I ask the surgeon that I've mentored, I ask him, look at the op note. Did they say anything about the arachnoid? Again, it's a thin, transparent. The spinal fluid actually is inside the arachnoid. The arachnoid and the dura are close together, but they're clearly separate membranes. And some surgeons will put in their operative note, I left the arachnoid alone. I opened up the dura, and I say to myself, that's fine. If you leave it alone, you can. But if there's a little hole in the arachnoid, then you can have, and this gets complex, but you can have fluid between the two membranes. The way I've explained it is you've got wallpaper on your wall. You make a little cut in it and you put a hose there, and that wallpaper is going to separate out. The arachnoid we can't see on MRI, so I have to rely a lot on the operative note and some other subtle clues. But the arachnoid can make the scan. Let me rephrase that. Your scan can look, quote, wide open. But if you've got a hole in the arachnoid and the arachnoid's been pushed in because of this fluid that's leaked, you essentially have no Chiari treatment. Now, before I leave this subject, the other thing is people having too much of a surgery. They've had too much of the support removed. The cerebellum has slumped, and that's causing its own problems. So there's a handful of things that we look at in the technique. And it's one of the reasons that I've been driven to at least share what's worked for us. I'm not saying it's the end all, but it is. I have treated over 1,000 patients, so I hope it's worthwhile to folks. But in summary, what I would say is a person that seems to have ongoing Chiari symptoms will need to go to one of the few specialists in the country, and I can always answer email. I help people find someone in their own state at times.
I was actually supposed to go to you the week after you retired.
Oh my word. Well, I'm so
Yeah,
sorry.
I ended up going to Johns Hopkins instead because they couldn't give me a date. And at that point, I was at a really, really bad place. But yeah, I was scheduled to go to you literally the week before you retired.
Oh,
the week after you retired,
anyway, I wish you the best. And
thank you.
You're welcome. Take care. Thank you so
Appreciate
much.
it.
Mm-hmm.
We have one more question, Doctor.
Okay.
Jillian.
Let's see, do we do it on audio or I can read it
Hey
here?
there. Can you hear me?
Jillian's here. Yep, we can hear you.
Hey, so for what you're just talking about with the potential hole on the arachnoid, do you have an example of a post-operative MRI that has a hole that you could show?
Yes, and yes, I do. And I have lectures. I have one very classic patient, and I took pictures of the arachnoid, which had been pressed up against the brain again, and you can see two clear holes. Yeah, I can give you a little more background on her. Okay, she was treated at a top academic center in the US. She was a nurse herself, had Chiari surgery, did not really improve. She saw her neurosurgeon. They said, look, everything looks fine. She then saw a second opinion in that same state. It looks fine. She then got frustrated, withdrawn, could not work. She happened to work as a nurse at the hospital that treated her. Her mother, about a year later, brought her to Colorado to visit us. I sat her, both of them down. I always show them on the computer, as most surgeons will do. And I basically said, you look open, but when I look at the note, there's no report. The arachnoid was left alone. And I'm worried because we can't see the arachnoid on MRI. I'm worried that something may be going on. Anyway, the long and short of it, to wrap up, she allowed me to proceed to operate. I removed the arachnoid so it wouldn't trap, and she recovered her life steadily. Anyway, that may be more answer than you needed, but it's fortunately, there are a number of neurosurgeons in the country that are very passionate about sharing, if you will, best practices. We tend to have at least a couple of meetings per year with the Chiari organizations and share what we've learned on the positive side and how to identify negative things. So I'm hoping that Chiari care will improve as we go on. Thank you.